My name is Dr. Christina Johns. I'm the Senior Medical Advisor for PM Pediatrics and the spokesperson. And I'm the gal who you usually see on the Facebook and the Instagram and the Twitter. And so tonight I've got, as you can see on camera, a whole bunch of my colleagues. Recall that last week, Dr. Eric Weinberg gave a fabulous presentation on COVID. We talked about, how do we get here and where are we going? And then we went through some questions. There were so many fantastic questions that we didn't have time to get through them all. And we said, let's try to do a panel discussion today. And so I said, I think that we should probably get some more friends to come on and get their expertise as well. And so here they are. In addition to what we're going to talk about tonight on camera, in the chat, some of my other pals are on as well, and they are going to help answer some of the questions that are there as well. And those people are Dr. Shannon Henning, Dr. Samantha Jackson, Dr. Saba Iqbal, we have Dr. Cheryl Cohen, Dr. Michael Bachman, one of our fabulous peds nurses, Patrick LaFontaine, is on. So look out for those guys. They'll help to identify themselves in the chat so that you know that you are talking to one of our experts. So what I thought that I would do right now is I'm gonna introduce everybody who are in this frame. And maybe what I'll do right now actually is ask them to unmute themselves. And I'm gonna, oh gosh, I guess if I point, it's a different frame for everybody on Zoom. So I'm just gonna say your first name. And if you can say what your role is and where you're from, then I would very much appreciate it. And golly, let's start with our company co-founder. Jeff, want to say who you are and where you're from?
Hi, I'm Jeff Schor. I live in Port Washington, New York, and I am one of the founders and CEOs of PM Pediatrics.
And a pediatric emergency physician.
Right. I am a pediatric emergency physician, yes.
Noted. All right, Gary.
Gary Gerlacher. I'm a pediatric emergency medicine physician, and I'm in the great state of Texas, down here in Dallas, Texas.
I like it. All right, Kristen.
Hi, I'm Kristen Crandall. I'm a pediatric nurse, and I'm the Director of Patient Safety at PM Pediatrics. I live in the Philadelphia suburbs.
Thank you. Bruckner. You're on mute or something. Can't hear you.
You're muted, Rich.
Is that better?
Yep, very good.
Rich Bruckner, pediatric ER doc from Long Island. I'm regional medical director of Long Island.
Great. Karin.
Hi, I'm Karin Sadow. I live in New Rochelle, New York. The first, but not the worst, the first hot zone. Yep. I am a pediatric emergency medicine physician, and I'm the Senior Vice President of Quality at PM Pediatrics.
Excellent. Jan.
Hi, I'm Jahn Avarello. I am a pediatric emergency medicine physician as well. I am recently retransplanted back to Florida from New York. Been there for 20 years and came to Florida to help grow the PM Pediatric Urgent Care Centers down here, with the first one to open in Parkland soon. Okay,
fantastic. And Parag.
Hi, I'm Parag Vora. I'm a pediatric emergency medicine physician as well, and I live just outside of Philadelphia. I'm the medical director of the Wynwood office.
Fantastic. All right. Thank you very much. Okay. And we're still going to work on getting Dr. Eric Weinberg on. I think we're having some technical difficulties.
He'll be on in just a second.
Great, thanks. Okay, very good. All right, look, let's get started right away. Couple of housekeeping things that I just want to remind everybody that while we are a bunch of doctors and nurses here, we are not necessarily your doctors and nurses, and it's going to be very hard for us to give very direct medical advice about your exact situation, since we haven't been able to examine your child, but we are able to speak to a lot of the themes that are going on and that I think can be very helpful. So just want to remind that it's always best to speak with your own doctor about, there he is, hi Dr. Weinberg, about your own individual medical situation. So I think that's just a really important thing to say right off the bat. And now that we finally have Dr. Weinberg on, can you tell us a little bit, sort of, Eric, your name, where you're from? You're the familiar face from last week though, go ahead.
Hi everybody, I'm the guy who can't figure out Zoom, but I'm supposed to solve all your answers about coronavirus. But I'm Dr. Weinberg. I am pediatric emergency medicine trained. I gave you a presentation next week. Hopefully you remember me from that. I had a blue shirt, now I got a black shirt. Everything else is the same. And my wife just gave me a nice haircut, so I would look good for you guys.
Nice.
And
Great.
I've just been reading ideally every article that's out there on coronavirus to get our group and hopefully you guys informed as well.
Thank you very much. That's great. Just want to remind everybody too, over in the chat, make sure that you click in the to box, drop down box, make sure that you write to all panelists and attendees so that make sure that everybody can see what you're saying in the chat. All right, look, let's kick it off because we've got, I don't want to spend any more time on housekeeping. Let's get right to the content. And I want to talk about what's hot in the news right now. And that is this very unusual Kawasaki-like inflammatory syndrome that we are starting to see in children. And I'm going to toss that out to Dr. Eric Weinberg. Eric, can you talk a little bit? I mean, people want to know, look, what is it first of all, and what do parents need to look for? And we can talk more from there. Go ahead.
Right. So, you know, this has certainly been disturbing, I'm sure, for parents and for medical practitioners like ourselves. And it seems to have appeared in the last 7 days or so, but it's a multi-system inflammatory syndrome, and that's a lot of big words, but the easy way to think about this, for some reason, after patients are having a mild version of the coronavirus or no symptoms at all, they seem to develop this widespread inflammation in their body. And this inflammation shows up in a couple of ways where we're starting to see these patterns. The big one is going to be persistent fever. For greater than 4 to 5 days. That seems to be the hallmark, and it seems to be consistent in all of these patients. The other symptoms that people are presenting with, you may have heard the term Kawasaki or Kawasaki-like syndrome. And what that means, there are certain signs and symptoms that we look for in the body that are little hints that this may be going on. Some of them include red eyes or pink eye. It could include swollen glands. It could include red cracked lips or strawberry tongue. Any number of things that could include changes to the hands in terms of like peeling, and it could include a generalized rash. The other symptoms that seem to be showing up a lot that's not really like Kawasaki is what we call gastrointestinal or GI symptoms, vomiting, diarrhea, and abdominal pain. But to be honest, it's a little bit tricky to pick up on now, other than the persistent fever, the Kawasaki-like symptoms, and the GI symptoms. So I think the take-home point is if your child is having any persistent fever, maybe more than 3 to 4 days, they should be evaluated by a medical professional, and they could decide if your child just has straight up fever or if there's something else going on. Just to kind of finish the story, what we're looking for here, or what we're concerned about, is that this inflammation, in addition to some of the signs and symptoms in the body, is showing up as inflammation of the organs in the body. It could cause inflammation in the kidneys and the liver, and most fearfully in the heart. And it's causing symptoms of what we call shock, which means impaired blood flow to the vital organs of the body. And sometimes it's putting patients in the intensive care unit with medicines to keep their blood pressure up. And unfortunately, very infrequent, or not very infrequently, they're ending up on a ventilator. But the good news is with supportive medicine, these patients seem to be getting out of the ICU and getting discharged home. We've actually had a couple of patients present to our offices, which we've followed up. And although they had, you know, a hospitalized course, they seem to be home and recovering, which is good.
Yeah. Great, thanks. Dr. Avarello, people talking a little bit about when this seems to present. Does it present in the midst of the COVID illness? Does it present after? Any sense on what the timing is here?
I'm going to mirror something Dr. Weinberg said as well, is, you know, these kids don't seem to have symptoms other than fever for a few days. It's not like they have 2 weeks of cough and whatnot. And actually only 25% of the patients that I've spoken, one of the facilities that had these patients, I spoke to them, there was 25% of the patients had cough. The rest of them really just had fever and then abdominal pain. So they're not really presenting like the adult counterparts that have these lingering symptoms that are getting worse and shortness of breath. So you really have to look for fever that's ongoing. Kids typically don't have fever longer than 3, 4, 5 days, as well as the other symptoms that he had spoken about, specifically the abdominal pain.
Mm-hmm. Yeah, and I think we really should point out that it's high fever. These are not kids who are looking well, right? So these are children who look very, very sick. And this is typically speaking, we think of fever higher than 101, 102. So this isn't a mild fever, and these are very toxic appearing children, right? So what do parents need to know? What is your guidance? Then Dr. Bruckner, you took care of, have taken care of this kind of patient. And so can you share a little bit about what your guidance would be for parents who are worried about this?
Yeah, I appreciate that. I mean, certainly if you have fever that's particularly high, or if you have fever that's really not responding well to proper doses of Motrin and Tylenol, that's concerning. If you have fever that's ongoing for, like we were saying, more than 4 or 5 days, and then the symptoms, you're going to look for like the abdominal pain, the rash, and certain subtle other findings. You can find tachycardia, which means elevated heart rate, things like that.
Yeah, and so there's a question too, Dr. Bruckner. We're using a pulse oximeter, home pulse oximeter. Is that helpful? Do you have any thoughts on that?
It really depends. Probably not for most situations. If you're finding that your child has respiratory distress, then possibly. But in that situation, you really should be seeking medical care. The pulse ox would also show potentially a heart rate, but you can check that with just a radial pulse pretty much yourself.
Yeah, right. Okay, very good. Thanks. All right, guys, let's switch really now over to antibody testing because there's lots and lots of questions about that. So first of all, can I ask Dr. Sadow, can you talk us through a little bit about what makes sense in terms of testing? When do you get the nasal swab test? When do you get the antibody test? What?
So anybody who is having symptoms currently, fever, cough, we recommend the nasal swab because that will be a sign of active infection. It's either going to be positive or negative. If the symptoms have resolved, we recommend waiting at least 2 weeks until no symptoms whatsoever, and then that would be you would be a candidate for getting an antibody test.
Okay, great. And how accurate are those tests?
So I'll first talk about the nasal swab. That's what we call a PCR. It basically has what we call a 70% sensitivity. So there's a 30% chance it's a false negative. For the antibody testing, the one that we're doing at PM Pediatrics, it's called the IgG. There are different types of antibodies, but the IgG is the one that is representative of longer lasting immunity. And the tests that we're using have a sensitivity of over 80% after 10 to 14 days, and then the sensitivity goes up to 90% after 21 days. So that means that there's a low likelihood of being a false negative, and the specificity is 98.5%. So if it's positive, there's a very good chance that it's positive for the COVID IgG. So a low chance of a false positive.
Okay, all right, very good. Okay, and can you talk through, Kristen, a little bit about the process for how people go about getting the test?
Sure. So at PM Pediatrics, there's a couple of different ways. What we'd recommend is if you're concerned about active infection or you're interested in pursuing the IgG antibody test that we're offering, is that you actually use our telemedicine application called PM Pediatrics Anywhere. That's a way that you can stay home and get screened, and one of our expert physicians will help determine what test is best based on your individual situation. The great thing that we're doing right now is really offering this to people of all ages. So not just children, if parents or other family members or people in the community have a need for this, we're really trying to meet that need. Basically what you do is you do a screening visit with one of the docs. You may see a familiar face that's on this panel today, and they'll guide you in terms of what test is most appropriate based on your individual situation. They then refer you to a team that we have scheduling appointments for the actual testing in many of our offices. We have testing happening in all of our regions in different spaces to try to be able to meet all of our patients' needs. And so we'll set you up with an appointment time. It's not walk-in, so you don't have to worry about waiting in a line with your child or additional exposure. For the antibody test, it is a blood draw, and we do use that in more of a phlebotomy style. It is not a finger stick. So we work with you and your family to really do that in the safest way in our office. And if it's a swab or a nasal test, we actually do that outside of our offices, and it's very quick. It's drive up, and sometimes you get out of the vehicle to get the test done, but you're in and out quite quickly.
Great, thank you very much. Dr. Vora, can you tell us a little bit, people are asking, what about people who don't have any symptoms, who never had symptoms? What should they do?
Sure. So people that haven't had any symptoms could certainly get the antibody testing, as they could certainly have been exposed in the past and not have shown any signs of symptoms in the past. The question is always, when is the best time to get a PCR test if you haven't had any symptoms? And the answer to that is really there's no good answer, because you could really have it at any time. So even if you tested today, you could test positive and you tested negative, and you could test positive tomorrow. So there's not really a great answer for that question. In fact, and I have had a few patients call and ask about that today. In fact, and just don't really have a great answer for them.
Yeah, it's a tricky one, right? It is. There's a lot we don't know, and I think that's really important to say. And Dr. Gerlacher, could you just share a little bit about why you think that it might be a reasonable idea? What could we use this antibody test for? And does it make sense for, if one person is getting it in the family, should everybody come and do it?
Yeah, so I mean, right now there's, we don't know for sure if you have absolute immunity. We don't know if you have long-term immunity. What we can say is that we are very confident you've been exposed to coronavirus. Based on what we know now, it does give probably some sense of relief in terms of you've been through it, you're less likely to get it again. We're going to need time to really get the data out there to say how long and how good is that immunity. I like to tell people that if I knew I had the IgG, I would be more comfortable going to the grocery store, but I would still be very cautious. I would not take my mask off and breathe deeply in a New York emergency room. It's not that kind of immunity. It's not a Superman cape.
Gotcha. All right, thank you. Lots of questions, Dr. Sadow, about the status, the FDA status of these tests. Can you comment on that a little bit?
I sure can. So there is no test that is FDA approved. There are select tests that are what we call FDA EUA, so emergency use authorization. And those are the tests that we are sending our specimens, those are the tests that we're using. So again, the FDA EUA, there's a select few, but no test is purely FDA approved.
Okay, great. Thank you very much for that. All right, and last one, can I get you on Dr. Sadow? What's the deal? Are insurances covering this test, or lots of people asking a little bit about that? What's this?
Yeah, so the labs themselves are going to be charging for the lab test. We're just not sure what that charge is, and it's that's whatever your insurance covers for the particular lab test.
Okay, great, thanks. We'll come back to testing because I know there's a lot of questions. I'm still rooting through all of the questions in the Q&A and on the chat. Dr. Weinberg, question about COVID toes. What on earth is that? Can you talk a little bit about what that means?
Sure. So COVID toes is a particular rash this is really just observational. There's been really no study on this, but the beautiful part about the response to this illness is there's been an incredible amount of sharing between the medical community. And what seemed to pop up basically about a month ago is this pattern where you get a redness and occasional blistering, some discomfort, maybe itching of the toes. I've fielded a couple of these calls on my telemedicine calls, and inevitably it's somebody who like, oh, I thought it was my shoes were too tight or so on. And then or I've been running a lot, and then I stopped running, and for some reason my toes are still really irritated, really red, and so on. And this is thought to be due to inflammation of the small vessels in the feet, which causes some of this discomfort, some of the redness, and occasionally the blistering. In patients who've had this, occasionally they've tested positive for COVID, although honestly, in our experience, it's been mixed. Some people have negative antibodies, some people have positive for the initial test called the PCR, but it is presumed to be a symptom of coronavirus. The good news is it seems to go away, but it does persist for several weeks.
Yeah, thanks. All right, very good. Dr. Avarello, lots of people are asking about, look, does it make sense to get this antibody test now? Why on earth would you do it now as opposed to waiting when maybe there are other tests that, that may be coming down the pike in a few months that may have better accuracy?
I think there's answers on both ends. It's not a bad idea to wait. The longer you wait, the more likely you are going to be positive if you are exposed. The body converts over to those IgG antibodies that are the longer term antibodies after around 14 to 21 days or so. So if you're only 14 days out and you're debating on getting it a month from now or 2 weeks from now, go it a month from now. It's really going to mean no harm. Now, as different local authorities, if they dictate that you must get a test to return to work or school or whatever, that may play into, into a little differently. But as far as your health goes, I don't think there's any difference to get it today versus getting it a month from now.
Okay, fair enough. Thank you.
Could I chime in?
You can indeed.
Yeah, so because I've handled a lot of these questions as well, and I think there's two potential benefits to this test. One is for the public health. It's very important for us as a country to understand how prevalent this disease is, how many people have it, and this antibody test is giving us critical information for that. So that one part is the public health, and the second part, as Dr. Gerlacher alluded to, there is knowledge is power, and it's very helpful to know if you've had the virus before. We don't 100% know if you're going to develop immunity. The physiologic thought is that it's yes, but we just can't prove it because it's too early in the illness. But knowing you've had the virus is a powerful data point that you can hopefully use in the future. That doesn't mean a better test may come out down the line, but the test we're using is actually quite reliable.
Thanks. Very good. Okay, we'll come back to that, which is a little bit like speed dating here, where we're jumping all around and doing a bunch of questions really fast. Kristen Crandall, a lot of people are saying, when can we go and see our grandparents again? Any thoughts on that? That's a tough one. It's a whopper.
That's a tough question. In my household, we've been having a similar conversation, so I feel the challenge firsthand. I think a lot of this is going to be regional. Some of this is going to be based on everyone's health condition in the family. And my biggest advice would be to think about the quarantining that every individual has been doing. If one person is not quarantining in a group, then you potentially are introducing COVID. And so, we can have it within small quarantine groups, but definitely continuing to avoid large crowds. Think through people's medical problems in the family, how vulnerable they are, and know that it's a very individual decision, but not one to be taken lightly.
Yeah, agreed. Thanks, appreciate that. All right, Dr. Vora, kids with weakened immune system, congenital heart disease, those are some of the questions on here. Are they at greater risk for complications if they get COVID? Your thoughts?
So from what we've been seeing, that so there are some kids with certain chronic conditions that are going to be at an increased risk for developing worse complications. Some of the medical conditions that flu causes worse outcomes with aren't necessarily the same conditions that we're looking for with COVID. With COVID, it seems to be the really more chronically sicker kids that are becoming worse affected.
Got it. Thank you. And I just want to make oh yeah, go ahead, Dr. Avarello, jump on in.
There's some data too to make people feel more comfortable. And I actually just spoke with somebody about this after they told me they heard that their kid had a 78% chance of dying if they got the disease. The CDC released a report about a month ago. Out of the 2,500 pediatric cases they had, 345 had underlying conditions. There were 4 potential deaths that are still under question whether it's related to COVID or not. So if you look at those numbers alone, even if your child has a congenital anomaly or some kind of underlying condition, they're still, thankfully, on a very low risk for getting a severe infection or death.
Eric.
Could I chime in as well, just to kind of tie into the Kawasaki? And this is something, Dr. Johns, that you mentioned, I think, to the news station on your interview earlier, which is, even though this Kawasaki syndrome and some of these stories we're hearing are scary, and some of them are definitely tragic, in terms of the overall risk, to agree with Dr. Avarello, the overall risk to kids is still extremely low for serious illness. In terms of the number of patients, who've been hospitalized in New York City, I think the data was about 15 up until a couple of days ago. That's out of millions of children in New York City. So even though we need to be aware of the potential for badness, the overall risk to kids is still quite low. We don't want to be alarmist.
Yeah, really important to keep those numbers in
Eric,
perspective. Yep, absolutely.
There's a lot of questions popping up about asthma specifically. Eric, do you have comments about asthma and how much of a risk factor that is?
I do. I got some comments about that, and I'm going to chime in this time all by myself over here. So look, here's what we know from the early data is that children with asthma are in fact not at any greater risk of COVID-19 than other kids who do not have asthma. So that data may change, but the early numbers are really bearing that out. So I think it's very important to say that. I've gotten a lot of questions about that in the media and otherwise. My child had RSV in February, which is another respiratory virus. Do you think it really was COVID? No, I don't. If they had a test for RSV and they had RSV, then it was RSV. So I think that is a really important comment to make. Parag, you want to add on?
Yeah, that's what I was getting at with the conditions that we look out for with the flu. We look at asthma or like all the respiratory conditions leading to worse outcomes. It's not so with COVID. With asthma, it's not really anything that's going to make COVID worse.
That's exactly right. Quick jump back to Dr. Weinberg. Lots of people asking about what you said about vitamin D and dosing for vitamin D. Yeah, okay, well, bring it. What did you say? How much vitamin D should a person get?
Right, so vitamin D, I just ordered some myself off of Amazon, so I'm with everybody out there. But, and again, to me, the data is still a little bit early, but whenever we're deciding what to do with something, you look at the risk and the benefit, right? So there appears to be very little risk to taking vitamin D, and there appears to be significant potential benefit for multiple reasons. And I'll get into the dosing. One is that it may have antiviral effects. That's been shown with the flu. In the winter, when winter viruses tend to be the worst, that's when vitamin D tends to be the lowest. And I think I was actually speaking with Dr. Sadow earlier. We were hypothesizing, I think all of our vitamin D levels are pretty low right now, given that we're not going outside at all. And there was an interesting study in Indonesia that found, it was a large, well-designed study where they looked back at patients who had mortality from coronavirus, and their vitamin D levels were very low compared to patients who survived, where they had tended to have normal vitamin D levels. Again, this is not a controlled study, but the difference between the two groups was quite large. So based on some of this data and the physiology, I would recommend trying it out, both as a preventative and to prevent the bad effects of it. And they're actually in the middle of doing very large studies right now. In the one study, the recommended dosing was 10,000 international units for several weeks, and then to go down to 5,000 international units going forward just every day.
And then what about for little toddlers and stuff? Gummies, or what formulation how are they gonna get that?
Wow, that I actually would have to look up. Maybe we can send that out at a later time. I don't want to comment if I don't have a proper answer. I don't know if anybody else in the panel can comment.
The exact dosing.
I think you stumped me.
Okay, all right. There's a first time for everything. Dr. Bruckner, comments about summer camp. Lots of people asking, is it going to be safe to go to summer camp? What's your thought?
I think that's going to be a really tough question to answer at this point. I mean, essentially, it depends on, is this a residential camp? Is this a transient camp, a day camp, something like that? It depends on the region you're in, what the current state laws are about gathering in groups. It's really tough, and it's evolving. I mean, if you ask this question 2 months ago versus now, obviously you're going to get a different answer. I think we're going to have to see in the next couple of weeks where the trend is heading.
Yeah. I know that a lot of some of the camps major camp organizations and umbrella organizations have already canceled. And so I think that people really should expect the high likelihood that sleepover camps will likely be canceled for the summer. Do you think that I'm crazy?
I think there's going to be a lot of modification, or very heavy modification to consideration of canceling.
Yeah, I think, unfortunately, I agree with Dr. Johns. I've been up and down on this. My kids are campers. I've struggled with this decision a lot, but I think we may be heading in that direction. I think it's going to be state by state. And I think the states could actually release certain guidance probably in the next 1 to 2 weeks. When speaking with our camp director, they're expecting to get some guidance from the state, and that may guide you either way, either to open up, like Dr. Bruckner said, in a very modified form, or to close altogether. One thing I did look up the dose of vitamin D if there's deficiency in children, and it looks like it's about 2,000 units for several weeks to get your levels up, and then 1,000 units going forward.
Very good. Any data for zinc?
So zinc is interesting. There's no controlled study like the one we found in Indonesia that gave us that powerful data. Zinc has been shown to decrease the duration of colds, not necessarily the severity, but the duration. I don't see any harm other than it can cause some mild nausea. So be careful, especially in kids. Yeah. But certainly no harm if you want to do it.
Dr. Avarello, newborns, any commentary on, are they more at risk? What do we need to be concerned about there?
So I can tell you about 15% of all the pediatric cases were under a year of age. Obviously, that's not the newborn period, but it gives you an idea of how many are presenting as far as the pediatric population. They are at risk, and if they do have symptoms that appear to be, shortness, not shortness of breath, but cough or fever, specifically fever outside of COVID is dangerous in a newborn anyway. So if they have fever, they should be an automatic phone call to your pediatrician, a visit to an ER, or a visit to your pediatrician. I think you have to have a low bar for actually bringing them in to get evaluated. People seem to be scared to go into the ER lately, and I think that's causing the opposite effect. Is some kids could get even more sick because they're scared of going to the ER. So bring them in and get checked out.
Yeah, that's a really important point. And I'm wondering if we could get Dr. Schor on camera. Can you talk a little bit about that whole concept of, we don't want people to wait too long. If you've got a medical condition that needs to be seen, you really need to go in, right? And there are offices that have made all kinds of accommodations to make sure that people are safe in offices.
Yeah, I think that's true in a general sense. I think what we're finding is that certainly in older populations, but definitely in kids, we're finding a higher incidence of things like appendicitis that's at a more advanced level than it probably would have been in previous times where parents would have brought their kids in to be checked out. I think if there are symptoms that are of concern and your pediatric office, whether it's a primary care office or whether it's an urgent care office like ours, and that they're, practicing good hygiene, cleanliness, everything else along those lines, I think the better part of valor, if you have concerns, is to bring your child in. Now, we've made major advancements in telehealth care, and I certainly think that the ability to screen a child via telehealth and get an opinion on whether or not something needs to be seen in this day and age is probably the better part of valor as well. But certainly, you shouldn't be fearful of avoiding a in-person visit if you think that your child has something that could be significant.
Yeah, thanks. Agreed. Co-sign, I think, from the rest of this group right here. Yeah.
May I add something to that point? Actually?
Yeah, please do.
I just wanted to say that, at the same time, we also want people to continue with their well visits, especially the young children that are on their vaccine schedules. We want to keep up to date with vaccine schedules, because if kids are not going in for their well visits and they're not vaccinated, they're more at risk for picking up all these other conditions as well that we're otherwise protecting against.
Agreed. Thank you for that. I saw there were a couple of comments as well in the chat, people asking about elderberry. Look, here is my thought on elderberry. Elderberry, I want to remind people, it's not a medicine. It's a food, it's a plant. And so as such, it is not regulated by the FDA. And I think that's really important to know, that you don't necessarily know exactly what you are getting in each preparation. And so is it likely to be safe? Absolutely, it is likely to be safe. Is there any good, reliable, validated data in children that shows that it helps? There is not. So people ask me if I recommend elderberry, and I say that I do not. I cannot do that given where the science stands right now. So I think the same thing for ginger, the same thing for a lot of those foods that I think those are perfectly safe to give, but I cannot give there is no validated data and solid research to back up its use. And that's a really important one. Thoughts, Dr. Gary Gerlacher? A couple of questions about school opening in the fall. What kinds of accommodations do you think are going to need to be made? I'm going to toss that to you and to Bruckner to answer those.
Yeah, so I mean, first of all, I think it's going to be very much a regional decision. So areas that have lower disease prevalence are going to have a lot easier time than areas that might be spiking. So first of all, there's going to be no national standard. It's all going to be on the local basis. And I think, you know, again, there's going to have to be accommodations. You know, trying to get a bunch of fifth graders to stay 6 feet apart is not realistic. So whether, you know, school districts are going to choose to go all virtual, go partial virtual, you know, have smaller classes. I know they've talked about potentially not mingling the classes when they're there, so the kids aren't all in the hallway at the same time. But there are definitely going to be changes. We just don't know what they're going to be yet.
Yeah, I think that's very true. And Rich, what's your thoughts?
Yeah, I think a lot's going to play out in the next couple of weeks as we learn what antibody protection actually means, right? So if you were exposed and you had antibodies, are you actually protected against it and immune against it, or can you get this again? That fact, and then eventually, hopefully a vaccine that would be, you know, potentially, you know, preventing disease. I mean, those are two major factors. But in the near term, social distancing rules and virtual platforms I think are going to be the way.
Yeah, I think there's a really good possibility that even, you know, in the fall that schools may try to do some really creative things that, you know, I think if there's, say you've got a class of 25 that, you know, 1 week there'll be a cohort of 12 who are at home and the other 13 are in the classroom. And then after a weekend of a big terminal clean in the school, maybe it would reverse. So I think there are going to be a lot of creative solutions that are going to be coming our way. Jeff, do you think that people ought to be tested, kids ought to be tested before going back to school and for antibodies, and that there should be documentation required? There's a lot of questions about that. Do you have any particular feeling?
I don't. I think it's a little bit too early to say. I think, like a lot of people have said in here, the notion of what antibodies mean still is to be determined. I mean, we know that antibodies that are positive will suggest that the person has been infected. What we don't know really is what protection that will infer yet. And so I think that there's a lot we're going to learn over time. I think as other people said, there's so much research going on and there's so much knowledge being accumulated on a day-to-day basis. I think we'll have these answers relatively soon. Yeah. But I think at this point now, it's a little bit early to say. I certainly hope that within a couple of weeks, we'll have better guidance on what a positive antibody suggests in terms of your ability to go back to work or go back to school or something like that.
And travel too. I think travel is going to be.
And travel, right.
Is really going to be part of it for sure. Absolutely. Kristen Crandall, a lot of people asking, can you get this twice? Can you get reinfected? What do we know? Do we know?
Unfortunately, we don't really know because it's still new. So we do think that evidence of some level of immunity through antibodies could help someone not get reinfected, but it's too early to tell for sure.
And can you comment a little bit, just because you've been monitoring our testing so very closely, just in terms of overall people who are coming in that are thinking they're positive? Are we seeing everybody who comes through our doors? And we've seen done several thousand tests already. And so is everybody positive? So are people right with their hunch?
No, so I'll quote some general numbers based on what we've seen internally. So for the test for active infection through the swab, overall, we're seeing about a 21% positive rate.
Wow.
And then with antibody testing, we just went live last Thursday. So our numbers of that are slightly lower, but we're seeing about a 13% overall positive rate. And so the simple answer is no. Most people who are coming in are not positive, either for the active infection or the antibodies. The antibodies will be very interesting to watch over time as more of the population is tested, and we'll be able to look at it kind of based on age, which I'm really interested to see what sort of data we see with that.
Yeah, I think that's very interesting too. And I think it's really important. Somebody made a point in the chat, and I would like to thank them, that there are other viruses still going around. And I think these numbers really support that. And I think people are shocked. They're saying, well, my kids haven't seen anybody in 6 weeks. How on earth can they be getting sick? And remember that, you know, viruses, different kinds of viruses are everywhere. And that despite our very best efforts in the grocery store and whatnot, it is possible indeed to have exposure to everything else on the planet. Gary Gerlacher.
Just want to mention too that our numbers are very heavily New York, New Jersey centric, and so I'm in Texas, and our rate we've had like 1 positive test, so it's not 20% across all of our facilities. It's very heavy in New York, but some of the other regions are much lighter.
Yeah, absolutely. Great. No, I think that's a really, really important comment. Dr. Avarello, do we still need to be washing our cans and groceries and fruit and stuff like that when we come back from the grocery store?
Oh, that is a tough one. I think it's going to be very tough, if not impossible, to wash every piece that comes in your house. I know there was a question about, can I wash my fruit with soap and water? Is that safe? And I'll tell you this, people are going to do it, whether we say to or not. If you're going to do it, if you're going to wash your fruit, make sure you wash it off with regular water without soap afterwards and get all that soap off of it before you feed it to your family. And it sounds silly, but I know there's people that, read stuff in the newspaper, see stuff on the news, and they're gonna follow suit. So just make sure that if you are going to do it, you really wash it off with water afterwards. I don't feel strongly neither here nor there on whether you have to do it or not. I personally don't.
Yeah, here's something that I kind of think is a sort of a slick trick. I really encourage people, when you bring your stuff home from the grocery store, have one area in your kitchen where you put all your groceries, right? So they're not completely spread out all over the place. And so you have one area where you handle your food and your groceries, put things away, and then make sure that mostly that you wipe down the surfaces where the bags were, those are the things that were really probably primarily handled. So you want to make sure that you do that the same place every single time, and then wipe down with a bleach containing wipe. I think that's a good trick. Dr. Weinberg, you wanted to jump in.
Yeah, I think the key point is, and I'm as risk averse as anybody, but I think, we bring our food in, one person unpacks them, and then they wash their hands.
Yeah.
And that's really going to be way more handy than anything else you do. If you want to go next level, like for example, my parents who are a little bit older, very healthy people, but in the older age group, if you have non-perishables, you could always just leave it because the coronavirus doesn't survive for a certain amount of time. It'll survive, the longest it'll last is on plastic for 3 days. And even by that time, it's going to be much, much reduced. So if you have non-perishables and you want to play it super safe, like find an area in your apartment or in your garage and just leave them there for 3 days and it's clean.
Yeah, totally fair enough.
I was just going to add, you just have to do whatever you're comfortable with in your household. I don't think there's any harm to washing off your fruit with soap and water. If you're going to rinse it off again, if you're going to feel better about it, go for it.
Yeah.
Very good. Dr. Schor, golly, this is going to be a tough one that I'm going to toss your way, but everybody wants to see their grandmother and their mom this weekend. And what if they put on a mask? And what if they stay 6 feet apart? What do you think about that plan?
That's a tough one, and that's a personal one. My mom is in a nursing home now. I haven't seen my mom since February because the home has gotten very careful about what goes on there and who comes in and everything else. And so that's a very difficult thing. I spend a lot of time on FaceTime and other things like that. I think a lot depends. I think it depends on who your parents are, who the people are you want to see, the age of the people, the health status of the people, and I think your knowledge of what's been going on. I think the better part of valor until things really settle down a little bit is that keeping a distance, keeping things as virtual as possible is probably the prudent thing to do, unless you have relative certainty of things being okay. But that's very difficult in this day and age. I can't give a definitive answer on that. I think there's a lot of personal involvement that comes into this, and I think people need to use their discretion. It's as you said, starting this, it's a tough question.
Yeah.
And tough questions have difficult answers, but I think it's an individual call.
Yeah. Dr. Weinberg.
Because I could tell you I've personally struggled with this. And one potential solution, especially when the virus rate drops in general, which is hopefully going to happen in June and this summer, is, and again, this is all individual, but if you're willing to go on full quarantine and shut it down for 2 weeks, where you don't go outside the house, you don't bring anything in the house, you do a big shop and you shut it down for 2 weeks, then there is potential to see people in a controlled way, and again, this is all just personal. This is all just based on, data and how your brain works. But one solution I came up with was we'll shut things down for 2 weeks, and then, maybe we could see my parents outside in the backyard with like a sitting area where they sit and an area where I sit, and we're 6 feet apart, and we maintain social distancing. But that's an individual discussion. But having a pre-quarantine before you see somebody who may be more vulnerable is something to consider.
Yeah. And what does that mean exactly? Can you just say really quickly, and then Dr. Sadow and Dr. Avarello?
Yeah, the hard thing is that with my family, we can't fully quarantine because I'm still taking care of patients. But if you have that luxury, if you're working from home, or if you're, if you're able to keep the family within the home without anything coming in or going out, like a full shutdown for 2 weeks, that's the typical period where if you were infected with the illness, you should show symptoms or be contagious. Keep in mind, there are some studies that show that you can shed the virus longer than that, but the great majority of patients will manifest illness and no longer be contagious after 2 weeks. So if you could do a full quarantine, where you have no exposure, no connection to the outside world, and then you go straight to that person and you do it in a safe way, that's just one idea. It's not written in stone, but it's something to think about.
Thanks. Dr. Sadow.
Yeah, hi, I just wanted to comment again on the original question about this weekend being Mother's Day. I think you have to think through the plan very well. It's very tricky because even if you invite your parents to come sit in the backyard and you say you're going to be 6 feet apart, I mean, what if they have to use your bathroom and you want to offer them a drink, something to eat, you have hamburgers and who touches the ketchup and passes it to somebody else? I mean, it's sort of a very tricky situation. So I think you have to think through that thoroughly before making any decisions.
Yeah, well said. Dr. Avarello.
I just wanted to personally thank you for reminding me it was Mother's Day this weekend. I think you just take me a lot of trouble.
Oh, brutal. It is a tough crowd. Oh my goodness. All right, I'm gonna.
I hope she's not on this call, Jen.
Yeah, right. That's it exactly. Okay, Dr. Weinberg, can you comment just a little bit on remdesivir, just on any therapies for kids, anything available as an outpatient? I think let's get through to that first of all, because I think
remdesivir came out, I think, approximately 1 week ago, that there was some encouraging data that it could lead to a 30% reduction in symptoms, duration of symptoms. There weren't really studies that it prevents serious illness, but there was enough potential that the expectation was it was going to receive FDA approval as an actual treatment. This is certainly not a cure, but I think it'll be part of the treatment regimen, at least in the next month or two, until we get some more studies. But there is potential that it could lessen the duration of illness.
Yeah, for sure. Yes, Dr. Bruckner.
Just want to point out that's an IV medication, so it will be used in the hospital. It's not an outpatient oral medicine.
Absolutely. And I just also want to say really quickly on hydroxychloroquine, people are still bringing that one up. And again, at this point, there is no evidence that we can sit with comfortably that is a medicine that ought to be offered widespread. And I'm going to just stop that conversation right there because that's what the science says. All right, Dr. Vora, question for you. Is there going to be a second wave of this darn virus?
It's really hard to say right now. I mean, people are saying that in the fall, there's very well could be, we won't have a vaccine by the fall. The earliest that we may see a vaccine is maybe next summer. And that's if everything goes perfectly according to plan. So it's really going to be unpredictable at this point. We just don't have any idea, honestly.
Yeah, agreed. I think it's highly likely. I'm going out there. I'm with my opinion here, and I am going to say that I think it's highly likely that we are going to see a second wave of this.
That would be my gut as well, yeah.
Yeah, I think that this is, it's going to come back around again. I'm hoping that with the warm weather, it will be less hospitable to this virus. And so we'll see a little bit of a dip, but I think there will always be some low level of positivity that's going around. And I think if we open up and people are unwise in terms of their behavioral practices too early, I think we should wrap our heads around the fact that we may need to shut down again in a while. And so I think that we ought to be able to be happy if we're wrong and that doesn't happen, but I think in all likelihood it probably will. Kristen, can you walk us through, a lot of people were asking a little bit, just in terms of back to antibody testing and how it actually happens. Do people have to have a screening visit on telemedicine, or how does that work? Really step by step, can you just walk through the process?
I'd be happy to. So I'll speak specifically to PM Pediatrics and the testing we're offering. And so yes, you do need to have a screening visit. We recommend doing that through PM Pediatrics Anywhere, our online telemedicine application. That screening visit is very efficient. It is going to ask very specific questions, and the doctor that sees you will quickly be able to determine what the correct test is for you. From there, that physician will send a referral to our testing center team with your information, and then they will contact you to schedule an appointment at an office that's convenient to wherever you live. In addition, one thing that we can offer, especially for adults, is if there's not an office close to you, we can send an actual order to LabCorp in some states and Quest in other states, so that you could go to one of their centers and have it drawn directly. But for those who choose to come to one of our sites, you would come at the time of your appointment, you park, and you call us from inside your car. And then we will give you instructions as to when we're ready to actually take you right to the room and have you tested. One of our great clinicians in the office will actually set you up. It's a phlebotomy blood draw, so it's a venipuncture. It is 1 tube of blood, and so they will talk you through that process, go ahead and draw the blood, and let you go on your way with some instructions as to what your results will mean when you get them in. Then we send it off to one of our partners in the lab. They run the test. Usually we get the results back in about 2 days, but it does vary based on the kind of demand on that lab. And then we let you know that your results are in and are available to answer any questions you may have.
Nice, thank you. Jan, Florida question for you. You know, I'm a believer that most of the coronaviruses are cold weather loving viruses. I think that is true, but my word, you're in Florida and it's hot. How come there's coronavirus there?
It's person-to-person spread. I mean, Broward and Dade counties, we have thousands of cases, and it's the hottest counties in Florida. I mean, yes, it's the southernmost counties. So it really is person-to-person spread. So although the virus is thought to be heat labile, I mean, you know, heat can eventually kill it. It clearly isn't doing it that much of a job because people are still spreading it.
Yep.
Population density has a huge part in it too. So you're going to look at the big cities.
Good point.
It's but one of the variables, right? It can, absolutely. It is, as I said before, there's a low level of this virus that will circulate. And I think that's similar to influenza. There are times when we see flu positive people in the out of season. And so I think that is an important point to be made as well.
On the same token, I've gotten the question of how come UV light doesn't kill it, right? It comes through the atmosphere and it should kill the virus, but it's the UVC light that really does the job, and UVC doesn't really make it through the atmosphere. That's where that comes in.
Yeah, that's a great point. Dr. Gerlacher, can you respond a little bit? People want to know, is it safe to order food and do takeout from a restaurant?
Well, I hope so, because I get like pizza 5 days a week right now. So I'm still here. You know, again, it is a little bit of a personal situation. I mean, you know, what is your risk tolerance? There is a little bit of a risk, but there's a risk going to the grocery store, and most of us need to eat at some point. So, you know, I think that most of the restaurants are taking precautions. You know, I know even our pizza guy is, like, before he hands me the box, is putting on a fresh pair of gloves and then taking them off and throwing them away. So, and they have social distancing in line and things like that. So you want to be careful, but, you know, you got to get food too. And sometimes you need pizza. I mean,
right.
You guys have pizza in Texas, Gary?
Pizza. We have good pizza. We have some chips and salsa too.
If I could comment, Dr. Johns, I think one good way to approach this virus is there's no way to eliminate risk. You have to minimize it. And I think I mentioned this in the lecture, and I think that's the best approach. Everybody's going to draw their line in the sand. So, you know, so you minimize risk by washing your hands, taking the pizza out of the box, and so on. But we also want to, like, support our local stores. We also need to keep our kids happy, you know, so, like, you really have to balance life, minimizing risk, and so on. And everybody's just going to decide where that line is.
Yeah, agree with you on that. And my understanding is since we're on the topic, is that SARS-CoV-2 does not survive with cooking food. So once you cook it, you kill the virus. So that's not really the risk. It's really largely who has handled your food, and that's really where the risk begins to increase. So I think that's an important comment. All right, so just to be clear, Kristen, what about testing outside, testing inside? There were a couple of questions about that, and risk management and mitigation as far as that goes.
Absolutely, I'm happy to clear that out. So the only test that we are offering outside is the swab, which is at PM Pediatrics, we're doing a nasal swab, and that is the PCR test, which tests for active coronavirus infection. The blood draw, the phlebotomy draw, is actually done within one of our offices in designated rooms. And so in both scenarios, we are practicing extreme infection control measures, following every CDC recommendation, and we are intentionally separating where we do this testing and using separate, staff and separate PPE, and really keeping these things far from each other. Some of our offices are offering both, but yet again, one is outside in a different part, and one is inside. Some of our offices are just offering one. And if you go on our website, you can actually see an outline of every office and what testing they're currently offering.
Great, thank you. I appreciate that. Dr. Bruckner.
Just to reiterate the point, you have to go through the app in order to get an appointment in one of these facilities. You really can't just show up.
Yeah, it's really best practice. It's quick and it's easy, and it helps kind of manage the efficiency for both you at home and for the staff to make sure that people are timed appropriately as well. Yep, great point. Appreciate that. Dr. Gerlacher.
Yeah, I just want to point out too, that PM Pediatrics Anywhere app that we're talking about for testing, yes. We are using it for testing, but it is also available for general pediatric care. So in all the states that we offer it, which is all of our states where we have physical locations, 8 a.m. to midnight, it is staffed by everybody you're seeing here on this board, as well as about 70 other doctors. We're treating over 2,000 kids a day on this thing. So we're seeing a lot of kids, and there's a lot of things we can handle by telemedicine, a basic rash, a gastroenteritis, just a pink eye. So I know some people are nervous about coming into the doctor's office, and if it's serious, you're going to need to come in. But if it's simple, the PM Pediatrics Anywhere app may be a great option for people.
Yeah. And you don't even have to live close to our offices in the states that we have them in either. If you want testing specifically, also we can send you directly to a lab as well.
And I think, Gary, just to add to that, 93%, if I'm correct, of our visits have been effectively treated through telehealth. So really the overwhelming majority of kids that we see on a telehealth platform can be effectively treated without having to come in.
And I think the other piece is that it's really very good guidance for people in terms of a gateway into the healthcare system, that if you're not sure exactly what level of care your child might need, then it can be very instrumental in helping to guide as well. So I think that's a really important thing. I'm seeing, do all New Jersey locations have telemedicine? All of New Jersey, you betcha, we can help you out in the telemedicine department for sure. Thoughts a little bit about a vaccine. Dr. Sadow, do you want to just talk through a little bit? There's a lot that's not known. I guess the question is, what do you think about this? And are we rushing too fast to try to push a vaccine out there? What do you think?
Yeah, I mean, it's tricky. You can't rush this. You really can't rush a vaccine. It has downstream implications. So, I mean, I think the earliest for a vaccine may be January. And then that would be my guess earliest. I'd love for it to be sooner, but it's gotta be good and safe. So it's a tricky question.
Yeah, without a doubt.
If you look at vaccine research in general, like most vaccines take about 10 years oftentimes, for fully. This is like really accelerated that we're getting this vaccine done, and they're saying earliest a year to a year and a half. So I mean that's the best scenario.
Yeah,
I think I'm a naturally hopeful guy. I think there's Hail Marys, and then there's the likely thing. The Hail Mary, which in football is a very unlikely play, but every now and then you get a completion on it. Pfizer and Oxford right now are working on a vaccine. And if everything lines up absolutely perfectly and it proves to be safe and it's effective and everything is perfect, that would be this fall. But that's that's best case perfect scenario, which doesn't seem to be happening with regularity. So like what Dr. Sadow, Dr. Vora said, most likely winter, spring is going to be the earliest. And look, just like some of the medicines and some of the tests, I don't think anything that comes out there is going to be absolutely 100% vetted, but I think there's going to be a lot of science behind whatever is released, and we'll have to make that risk benefit decision at that time. And if there is potential benefit of saving hundreds of thousands of lives, then it may be worth it to put it out there, in a slightly faster fashion, as long as it's safe and it's well researched and so on.
Yeah, excellent comment. We're gonna, it's 10:03. Last time we stayed up a little bit late also, and we will hang on for maybe 15 more minutes or so if people wanna stay up with us and answer a few more questions. Anybody in this panel want to comment a little bit? Jan, I'm going to toss it over to you to start about this, the whole concept of this virus mutating. What the actual heck with that?
I'm not comfortable really answering that one because I don't think anybody really knows. The evidence is not out there. We just don't know. The coronaviruses don't typically mutate. I know there's a lot of information being spread out there about the potential, or we just don't know.
Yeah. I mean, even today, there were two competing studies, one that said it may have mutated in Europe and now it's more contagious. And then another group that said like, those guys are completely wrong and it's not mutating. So I agree with Dr. Avarello. I think right now it's just a little bit too soon to tell, other than the early evidence seems to suggest that it doesn't mutate at a high rate, which is a good thing in terms of immunity and for a vaccine.
I just wanted to comment because I know there's a lot of people who don't understand, mutate versus change, or this is not like the flu virus. The flu virus changes every year. It's just, that's what it does. It has a little piece of it that changes, and that's why you get sick again from the flu over and over. Coronaviruses don't have that. So a mutation will be a completely new development for something like this.
Yeah, if I could add one thing too, just in terms of mutations. I mean, people always assume that they're bad mutations, and actually the overwhelming majority of mutations are beneficial to humans because the virus mutates out of a way that is harmful to people. That's what happened with the previous coronavirus with SARS. And so, the concept of mutation is not always a bad one, although I agree 100% with what everyone had just said before.
Great. All right. Look, let's talk with Matt. There have been a couple of questions about masks, and we haven't hit that at all. So we're going to hit it. I'm going to start, and I'm going to toss it over to Kristen Crandall. So people are asking a little bit about, should I mask my 3-year-old? What about younger kids? Here's my comment on that. Masks are not meant for children under 2. They can be a suffocation risk, and so would advise a firm negative on masks in that age group. The guidance really is to take that age group out as little as possible. If you must go out, because sometimes that's how it goes, if you must go out, then either having them in the stroller with a cover over it or infant carrier. That's really the guidance, but do your best to keep them out of public as much as you possibly can. For kids who are older than that, it is a little bit of a trickier thing because obviously it can be hard to negotiate with a 3.5-year-old to keep their mask on while you're through the grocery store for the entire trip. And I think that a couple of ways to do that are, there are lots of masks that are like a costume. I think so practicing at home is one way if you have to go out before. Some incentive and setting kids up. Obviously, the older that children are, the easier that this is. Hey, if you wear this, then we're gonna pull a coloring page out of your favorite coloring book. Whatever it works as a positive incentive and reward can also can be helpful. Adults have been asking as well, and this is where I'm gonna turn it over to you, Kristen, about best practices for adults reusing masks, and what would you advise people? Do you need to have an N95 when you're going to the grocery store? Your best thoughts and guidance.
Or I will say every mask is a bit different. So if you're using a disposable mask, you should follow the manufacturer instructions. There are lots of things out there online that tell you how to disinfect disposable masks. And I would really advise against engaging in some of that, because there's no evidence to say that those things do not disrupt the integrity of the mask and therefore lower their protection. I know right now most people are getting fabric masks, which I think are a great option. Really, my general advice would be if you wear it outside the home and there's potential that it's come in contact with anything, you should be washing that. You also need to be very careful when putting on and off the mask. If you're touching the mask, now know that whatever was on the mask is potentially on your hands. And so really, I stand by the single most important thing to do is really great hand washing. So when I have to leave the home and touch any other surface, I am constantly using hand sanitizer if I'm on the go, or washing my hands, and trying to be very mindful of anything coming near my face, including taking the mask on and off.
Yeah, excellent. Agreed. Dr. Bruckner.
I was just going to add the point that from my perspective, under low risk scenarios, the most important part of the mask is the fact that it reminds you not to touch your face, because it reminds you it's a barrier, it's a physical barrier. It's not trapping air. It's not a sealed environment, but it just reminds you, just don't touch your face.
Yeah, that's a great point. Absolutely right. And what about guidance, Dr. Weinberg? Do people need to change clothes when they come home from work? What's your sense of that?
It's a good question. Nobody really knows the answer to that. They haven't really studied coronavirus on fabric. They've studied it on cardboard, and it appears to be able to last about 24 hours. And that's the closest analogy to fabric, because there's somewhat of an absorbent material to that. So when I come home from work, I change immediately. Sorry for the neighbors, but I like to change as soon as I come in, put it in a separate hamper, put on a fresh pair of clothes, wash the hands and face, and then hugs for everybody. But everybody, again, that's more of a personal decision. When my wife goes, my wife or I goes to the store, same thing. When we come home, we just change just to make it feel a little bit, I don't know, saner, safer. Nobody really knows. I think that's more of an individual decision. I know there's been some questions about shoes as well. I think just taking your shoes off at the door and keeping them there is the way to go. They don't recommend, or I would be careful about washing your shoes, because chances are you're just going to take whatever on there and put it on your hands. So I think as long as the shoes stay in one place and you're not moving them and touching them, I think you could just leave them there.
Yeah, thank you. Dr. Weinberg, I'm going to ask if you can type in the chat for all panelists and attendees to see, while Dr. Sadow is going to answer this next question, what your vitamin D dosing guidance is. Again, there have been multiple people asking for a repeat. That has been the hot topic for this. So if you could write that out for everybody to tune into the chat and see, then that would be great. Dr. Sadow, just want to ask you, lots of people are asking about repeat testing and should I get repeat tested? This is one, I think that's a complicated answer to. Do you have any sort of thoughts or guidance, even if we don't exactly know for sure?
Yeah, so we don't exactly know for sure, but I've been trying to look at the chat. It's kind of hard, and then sort of listening to the questions. So I'm not quite sure if it was that if an antibody test is negative, maybe when to repeat the test is perhaps the question that I saw. I mean, listen, if an antibody test is negative, it's either that you weren't exposed to the virus, or you were exposed to the virus and perhaps didn't build up an immune response, or maybe it's too early. So in that case, we recommend maybe waiting 14 to 21 days later. And if you feel that you want to get retested, I mean, that's fine. But we just, again, it's sort of tricky, and we really don't know the right answer or guidance on that.
Yeah. Anybody else with thoughts on that one?
I mean, I would say the timing of antibody testing is yet again a very individual, personal decision. I saw some questions come across the Q&A about us panelists and if we've been tested. I'd say even among this group, it's very individual. Some of us are in our clinical offices several times a week, providing direct care to patients in different environments. Some of us are more curious than others. Some of us have high-risk individuals in our home. And so you really need to think through all those factors and read about whatever test you're thinking about getting done to fully understand what information it may or may not offer you, and then decide if and when the best time of that test is.
Yeah, that's a great point. And I think also to comment again, Dr. Weinberg, can you remind us that the further, in terms of the antibody test, that it is your results are better, as it were, more likely to be more accurate the further out you are from symptoms.
Absolutely. So the body takes time to generate the antibody, the IgG. So the longer you wait, the more chance you have that that your body made the antibody, and the more chance you have that the test is positive. So like Dr. Sadow mentioned earlier, the accuracy of the test goes up the farther away you are from symptom onset. So once you get over that 3-week range, the accuracy of the test is 98% or higher. So so if it's been that long and it's, then you can trust the results a little bit better.
Great, thank you. And Dr. Sadow, more questions in the chat. Are we using reliable tests? Anyway, we've heard that there's some not so good ones out there.
Yeah, so there's some not so good ones out there. That's true. We waited until we felt that the tests that we had access to were reliable, and the ones that we have access to and that we're using are the most reliable ones out there. They're what's called FDA EUA approved, so emergency use authorization approved. And that's why we went with those and feel comfortable that they're the most accurate ones out there. No test is 100%, but we feel the ones that we are using are the most accurate ones available.
Great. Thank you. All right, last couple of questions here. Thoughts about an increased BMI putting you at risk? I think that's been the case in adults for sure. Anybody want to comment on that in children? Dr. Bruckner, do you have thoughts?
I think any major underlying comorbidity can put you at a higher risk. I mean, we spoke about asthma, not particularly, if you're having obstructive sleep apnea because of a BMI, if you're having hypertension, renal issues because of the kidney issues, certainly possible, but I'm not aware of it being an independent risk.
Yeah, thank you. Dr. Vora, question for you. What about kids being able to transmit the virus? Do we have any idea that whether or not they are better at it, not transmitters? What are they?
Right. So I don't think we really have enough data on that aspect. The suspicion was earlier on that maybe kids were transmitting this virus asymptomatically, and maybe that's how it was spreading in many places. But we just don't have enough data, and that's why I think that this antibody testing is actually really, really important, because as Dr. Weinberg said earlier, we will get a much better sense as to the prevalence of this disease in different regions of the country. The more we're able to do this antibody testing, we'll know how much of each area was truly actually affected.
Yeah, I think the public health infection surveillance element here is an important mission, important responsibility that we have. We need to understand better the full scope of what's going on. Yeah, I absolutely agree with that. My thoughts on kids as well. People ask me about this all the time, and how are they? We've heard that they're affected less severely. So does that mean that they're transmitting the virus less than adults? And I don't necessarily think that that's the case. I think that there is it's very likely that children can transmit this virus just fine. And I think that even if they are less good at it, for lack of a better word, I think the mere fact that when schools open back up, and regardless of whether or not there are 10 kids in the classroom or there are 25, I think that they are going to be in closer quarters, and that's why kids get sicker, get all those viruses in the first place, because they're together in an enclosed environment where they are sharing germs. And so I think that we should not be counting out kids as vectors of this infection.
Absolutely. I mean, there was a study that was released, I think yesterday, that echoed just that, where they said that even though kids are getting it at a reduced rate, their contacts are so much higher. They just see so many more other people. So it ends up balancing out, that they get it at a lower rate, but the contacts are higher, so they still spread it. They're still contributory towards the spreading of any pandemic, unfortunately.
Yeah, that's right. All right, a few more hot ones. Dr. Avarello, ibuprofen, can we use it in COVID?
Yes, absolutely.
We can.
Been pretty much debunked.
Yep, very good. Okay, fantastic. I like that one. Can a person who had the virus infect another person who doesn't have antibodies after the person who had the virus was in quarantine for 2 weeks. In other words, how long do we think somebody is contagious and can infect others? Eric.
So good question. It's a little bit unknown. I could tell you what the CDC recommends, which is they recommend 10 days after symptom onset, fever resolved for 3 days, and improving respiratory symptoms as clearance to go out back into the world. You know, the 14 days isn't a bad number because most of the data suggests that within that 14 days, by that time, you shouldn't be contagious anymore. But keep in mind, there are outliers. You know, there have been studies of patients who have remained infected for several weeks and can continue to shed. So unfortunately, we're still learning that a little bit. So I just go with CDC criteria at this point.
Great. Yep. I think that's good advice. Absolutely good advice. So a final comment that I want to make that people are still talking about, and that is, do we need to wear a mask when we go outside and we're in our backyard, or we're on the street and we live in a neighborhood where there is not highly population dense? And I want to remind people that a coronavirus doesn't necessarily come swimming through the air to fly at you and jump on you, right? So it is absolutely okay to, when you are the only person in your backyard, just your immediate family, it is okay to be without a mask in that environment. When I advise people, if they're going out on a path, on a walk, neighborhood path, what have you, to bring your mask along. But if you are seeing people 50 feet in the distance, do you need to put on your mask? You don't. We need to get outside. We need to get our kids outside. We all need to have some balance here. As Dr. Weinberg said, this is not about always complete 100% avoidance. It's about decreasing your risk as best as we can. Dr. Gerlacher, did you want to make a comment about that? You're saying yes. Yes, I agree. I see. Okay, very good. Good. I'm glad. So I think that's a really important message. We are going to get through this. I think everybody on this panel, I think, can acknowledge the difficulty that the challenge that this has been for all of us. I think as a culture, as a society, as parents, trying to do the remote schooling thing or daycare, trying to manage that and work at the same time, it has been a challenge. I've been really impressed with what I have seen on the whole for how everybody is handling it, the resilience and the resilience of kids. Final question that I want to put out to anybody in the group. You know, this is a tricky thing for kids to handle psychologically and socially. I worry about it for my kids. Any thoughts, any tips? We've got, I think every one of us on this panel is a parent, and we've got kids of varying ages, from young adult kids to little ones, and moms to be. So thoughts on that, how you're handling it, the questions, and making sure that they have the kind of mental health support. Thoughts on that, anybody?
I could start. I mean, I try to go with the truth, but a slightly edited version. I guess I don't like to lie. So I tell them, look, you know, you guys, the risk is very low for kids, you know, and that's a true statement. So I could say that, and I say, look, the risk for you guys is very low. I don't think they need to hear about Kawasaki syndrome and all of these other things. They need to know that they're safe, and they are. So I say the risk is very low. Mom and dad are healthy. The risk for us is low as well. Dad, you know, wears a lot of protective equipment at work, so the risk for him is low. I think they need to hear reassurance that they're okay. I think they're absorbing a lot of negative and a lot of scary stuff, and we're all seeing manifestations of stress in our kids. So I think just a lot of reassurance that they're okay and that you're going to be okay and grandma and grandpa are going to be okay is the best thing for them.
Yeah.
Yeah, I agree with that. I have teenagers, so it's more truthful here in this house, and you know, we definitely tell them the facts. So I think it's really age dependent. I will say this: it's really important to, you know, make sure they get outside and exercise and, you know, connect with friends how they can, you know, virtually. But again, it's age specific. So if you have older kids, you know, they hear the news and then they want to know the facts from you. So I think it's okay to be, you know, sort of a little bit more transparent with them. But I agree with Dr. Weinberg, the younger kids, they really just need that reassurance.
Yeah. Yes. Kristen.
As a mom of a young one, this has kind of been tricky to navigate because he doesn't yet understand what a virus is. And so what we've been doing at home is trying to find outlets for him. The biggest thing is he doesn't have any siblings yet, and so he has no interaction with other children. And so we've really had to shift our mindset about how we play and interact with him. And he's also very young and a sponge. And so we've had to be extra mindful of how our stress levels are translating to him, and trying to come up with new strategies to cope with that, since a lot of the time we're all in the home. And so going outside has been extremely helpful in the comfort of our yard where we all feel safe, and coming up with some new and exciting activities. I've placed several orders online for new things to do, and bringing them out at strategic times. And that's been really helpful to us at home.
Yeah, I think that's great. Dr. Bruckner and Dr. Vora.
I was just going to say, I think we're handling this a lot differently in 2020 than we would have handled this in 1995, right? The virtual communications techniques that we have to get in touch with family members and grandparents really have made a huge difference. I mean, you see that in the virtual schooling that we have of our children. We all have much more respect. We've always had respect for our teachers, but we even respect them more these days. And I think it's allowed us to be a little bit more creative in our response and our approach to our kids. And it's helping them in ways we used to think that virtual stuff was, too much screen time for your child. Now we're embracing it a little bit more and utilizing it more.
Yeah, thank you. Dr. Vora.
Yeah, I mean, I'm in the same boat that Kristen's in. Actually, my child is probably the youngest one out of everybody on here. She's just a little bit over 2, and we'll go outside with her every single day, pretty much, just to take her outside. And the part that I feel lucky about is that she doesn't understand she doesn't know anything about this, and she likely will really never know what it was like, because to her, really almost every day is still the same.
Yeah, that's right. Dr. Gerlacher.
So my children at the other end, they're in their 20s. And my daughters, I have twin daughters who are 20, and they were presumed to be positive. They had fever for 22 straight days. And there's really not anything else that causes fever for 22 straight days. But what was really neat about them is, I told them that their job is to make sure they don't infect anybody else. And they literally locked down for 25 days. And if you want to lock down a couple 20-year-old girls for 25 days, I got some pointers for you. But no, they're very proud of the fact that they did not expose anybody else at all during that entire time.
Yeah, that's fantastic. The other thing that I really encourage parents to say to their kids, I'm a little bit older than what Parag and Kristen have, but I really say to people, tell your kids if they say tell you that they're being anxious, that they're anxious or that they're nervous, let them know that they're brave for being honest about their feelings. I think we've got to reframe the conversation around nerves and anxiety and concerns in kids. And that this is, thank you for being strong, for admitting your true feelings. It takes a strong person to do that. And I think that is an important thing to tell kids, to start to teach that, to role model that to your kids, so that they get comfortable talking about difficult stuff. And this is certainly been that in spades. And as much as we can encourage children to do that and respond in kind, I think that we will teach them to be better humans and better adults in the long run. So with that, I think that our time is up, and I hope that this has been an informative session for everybody, for the almost 600 folks who joined. So grateful. It is really been a pleasure to spend this time. I want to thank very, very much the folks up in this Zoom screen, as well as our amazing colleagues who have been in the chat, chatting away. And that's like an Olympic sport, I think. So really well done to get out there and share your expertise. Thank you very much, Dr. Cohen, Dr. Jackson, Dr. Henning, Dr. Bachman, Dr. Raskus, Dr. Iqbal, Patrick, thank you all very, very much. We will do this again. Just want to let people know where you can find us. Probably the easiest way anyway, find me on social media. I'm at Facebook, Dr. Christina Johns. I'm on Instagram, Dear Dr. Christina, and on Twitter at DRC Johns. So come find me. I'll share stuff from this group on those channels. PM Pediatrics has channels as well. So nice to meet you on there, and we'll look forward to doing this again soon. As a reminder, if you want to try to find more info about our telemedicine or telehealth platform, pmpediatrics.com, pmpediatricsanywhere.com can get you information not only about testing, but about our telehealth platform. We've got lots of content on there. Click through those pages and check it out. I think it will be helpful for finding out more information there. So thank you everybody again for joining us, and wish you all a very, very good night. We'll do this again soon. So thank you again and good night.